Welcome to this week's edition of Freedom and Prosperity Radio, the weekly radio news magazine that we put together here at the Virginia Institute for Public Policy so that you have better and more in-depth information. So when you run across somebody at a Halloween trick-or-treating party or a costume party of any kind, and they're dressed as, I don't know, perhaps Arthur Dent, and you have some better answers when they start spouting some crazy nonsense. There you can say, well, no, I heard on Freedom and Prosperity Radio. And up to kick that off, you may have, if you are anything like me, and read all the Real Clear mastheads, Real Clear Politics, but there's a bunch of them under the Real Clear masthead. And one of their newspapers is Real Clear Health, and a great piece titled, Don't Buy Into the COVID Relief Spending Spree by Dr. Chad Savage, who is on with us this week to kick us off this week. Dr. Savage, wonderful piece that you had published there. Thank you for taking a little time out with us. And you're also the founder of an organization called YourChoice Direct Care, are you not?
Yeah, I absolutely am. But I would think the most important thing is to know what type of Halloween parties you're going to where people are coming dressed as Arthur Dent.
Actually, that's me. I'm the one who goes dressed as Arthur Dent. Although everyone thinks I'm dressed as the dude from The Big Lebowski because it's basically just a bathrobe and pajama pants. But and then, sadly, I had never seen that. I had read all the Hitchhiker's books, but I had never seen The Big Lebowski. And then once I did, I got it, and I realized that now it wasn't an insult that I didn't.
Yes, sorry. I wasn't dodging the question there. No. I just found that a pretty fascinating Halloween costume. My practice, YourChoice Direct Care is actually an individual medical practice, but we practice a type of medical care called direct primary care, which is a much broader movement within the medical community of trying to get away from the insurance company and governmental payment system. So just quickly what we are, and again, these are a bunch of independent practices. Everybody's a little different, but they're membership model practices that for a set affordable, budgetable, and predictable monthly membership, they provide all the primary care services that person needs and can consume. So we usually don't charge for individual visits, no co-pays, anything of that sort. We usually work with the person's catastrophic coverage or insurance plan or health sharing, whatever coverage product they want for services beyond what we can do, and to try to make it as affordable as possible, we throw in or do at cost generic medications, laboratory services, imaging services, and the like. So we're really trying to actually truly bend the cost curve instead of simply obscuring it through subsidies, which is the governmental approach.
Oh, and I don't want to belabor because the COVID spending spree is out of control in so many ways, and we hide it under the banner of we're just trying to help. But the direct primary care model is one that I guess we don't spend enough time promoting the idea of it. But you mentioned in conjunction with catastrophic health insurance, that's if you have a car accident or all of a sudden you cancer diagnosis, the things that if you're old enough, you remember the original health care insurance that from your employer was generally a couple of bucks out of your paycheck, and it gave you an insurance policy, very much like the minimum coverage for an automobile. It'll cover, if something extremely bad happens, but it didn't try to cover everything soup to nuts. And those in conjunction really are a great way for people to save hundreds and hundreds of dollars a month on healthcare premiums and actually wind up with better outcomes.
Oh, absolutely. I mean, the amount of middlemen that have been injected in the system have not contributed to the care. They've actually detracted from it and monumentally increased the costs, all while eroding the doctor-patient relationship. So what's occurred in healthcare is truly abysmal. And actually I wrote a piece in townhall.com a couple years ago because when I opened my practice in 2015, I left the hospital system and had to get my own coverage product, and I got an alternative to traditional coverage called health share. Health sharing ministries are much more affordable coverage products than it is traditional insurance. And I combine that with direct primary care to get first dollar coverage, which is just another way of saying I don't have to pay when I go to see my doctor. So I use this model of practice myself. And in a 5-year period of time, by simply changing our coverage and accessing better pricing when we did seek care through direct primary care, my family saved $88,000 over the premium cost alone for traditional insurance. And if you did that across society, the savings would be truly amazing and could totally eradicate the deficit spending that we have.
Well, what about incorporating a health savings account? And I know we have sort of a kissing your good-looking cousin version of health savings accounts, so the politicians can say, well, you have them. You have to divest them. In some cases, some states, you have to divest from them within a year. You can hold on to them a little bit longer. But I've made the case you could actually mothball Medicare if you allowed people to save this year over the year the way you save a 401k. People would have so much money saved up, they'd be gifting health care to their grandkids.
Oh, there are amazing opportunities that are not fully being utilized, and I would really encourage those as the health policy advisors for the various congressmen and congresswomen out there to look into these options. Some of these are already in the law, such as the medical savings account, which are actually a Medicare version of HSAs. So that's something that should be looked into. There's what's called FSA. That's the time-limited one that you referred to, that if you don't use it by the end of the year, you lose it. There's some advantages to that one, but that one's pretty limited. HSAs are truly underutilized. HSAs are the optimal savings modality. They're better than a 401k if used for medical purposes because you're not taxed when you contribute. You can invest them like a 401k in the market so they can grow tax-free. And then as long as you use them for medical purposes, they're also tax-free utilization. Even a 401k is taxed at some time. So there's no point where that's taxed. And the only things limiting it right now is to have an HSA. You have to have them attached to a traditional insurance product that's high deductible. And that was done by the insurance companies in the 2000s when the HSAs were passed because they recognized that this was a threat to their very lucrative industry. So they made it so you had to attach it to an insurance product. Well, the Personalized Care Act, which Senator Cruz had introduced and is still sitting out in mothballs somewhere, could be resurrected, actually sought to decouple HSAs from the high deductible so you could have that alone, which would get rid of your need for employer-based insurance because employer-based insurance is purely based on the fact that it's pre-tax. Well, if you have an HSA that you can use to buy insurance, to buy health sharing or something like that, you no longer have to get it through your employer. And it would truly revolutionize how we practice medicine, putting the doctor, again, accountable to the patient and restoring that doctor-patient relationship. But again, I apologize. I digress from
No, because I think this is an abstract of everything that we talk about here, which is there are very simple right answers. And you also said something important there as well. This also recreates the doctor and patient relationship that a lot of people I talk to, regardless of political affiliation, say, I just miss, having, being able to call my doctor and say, hey, it hurts when I do this. And they miss that. And I think it does come back in your model.
Well, we all do that already, and we've been doing it since 2015. So, we schedule in 30-minute and 1-hour blocks. We have telemedicine available at no additional cost. We have smaller patients panels, so we can get the patients in same or next day. The least expensive place to access medical care is a primary care office. But the insurance design right now is to try to pinch and grab every drop of productivity out of the primary care offices. They've saturated them, which means now if you have an acute need, you can't go in to see your primary care doctor. You have to go to the ER. And a lot of times you'll call your primary care doctor and they'll say, no, you've got to go to the ER for that. We don't have an availability today. Well, that's the individually most expensive place to access care is an ER. Right. So because they have trauma teams and crash carts waiting for that, car crash to come in, and instead you come in with a cold that could have easily been handled by your primary care office. Well, so I would actually argue that we shouldn't even call it health insurance because it's deviated so far from the intention of insurance. The intention of insurance is to reduce catastrophic financial loss. You have your home insurance to cover your house in case it burns down, because that would probably bankrupt you if you didn't have that kind of insurance. Mm-hmm. But you don't purchase home insurance to clean your gutters, because that would make it, that would be more of a paid plan. You're going to do it with some regularity. And now you're adding a bunch of middlemen who would put stipulations about certain companies you have to use, and you can only use it at a certain frequency. And we shouldn't be doing that same kind of illogical approach to medicine, but unfortunately we are.
Dr. Chad Savage is on with us this week on Freedom and Prosperity Radio. Terrific piece published in the online magazine Real Clear Health on one of the pages under the Real Clear masthead, titled Don't Buy Into the COVID Relief Spending Spree. Dr. Savage, so talk about this, because we're still watching municipalities saying, well, we have CARES Act money that we're going to spend on buying a new truck for our sanitation department, or we have CARES Act money that we're going to use to hire an equity director, or it just seems like there's always something on every municipality's agenda that's reallocating CARES Act money for something else. Take us into your column a little bit.
Well, absolutely. I mean, the fundamental crux of this article was to try to bring awareness to the societally suicidal levels of spending that we are currently having within our federal government, of which medical is one of the largest components. So far, between the administration and the Congress, there's been an allocation of over $7 trillion for COVID relief. Those are numbers that are so preposterously absurd that they can't even be fundamentally grasped when you're talking about in the trillions of dollars. So I think that this is a incredible red flag for society, because you can't continue these levels of spending before eventually the monetary system will collapse. And I don't mean to be hyperbolic on this, but when it does, it will be like Cyprus 10 years ago, where you just wake up one morning and people have lost faith in the currency. It's no longer valued. And you try to go to an ATM and withdraw, and they'll be shut off, just like they were in Cyprus. And I think we're on a crash course for this unless something dramatic is taken. And I hope that people look back and we make those adjustments and they go, why were you so excited about this? It never happened. I will pray that that's what occurs. But if we continue at this course, we're really looking at a devastation that is just a matter of time before it occurs.
Well, and talk about, especially as healthcare, something, that is so essential to us, that is going to happen if we have that crash economically, because a lot of people talk about, well, this country, that country went through it. It wasn't to the benefit of the citizens, especially right after the economic collapse came.
Yeah. So, if I can for just 1 second to digress back to when we're talking about trillions, we've moved the Overton window. If you think back to the Austin Powers movie, if you remember that from the 90s, where they had, Austin Powers was a secret spy and he was cryogenically frozen, and they woke him up to combat Dr. Evil, who was also cryogenically frozen from the 60s. And when Dr. Evil was going to, try to extort the globe, he threatened to charge them $1 million or extort $1 million. And then everybody kind of snickered and, shrugged their shoulders and laughed and told me, you can't speak in the millions. You've got to speak in the billions. Well, since that time, we've now exceeded that, and we need to talk in the level of trillions. And if you took a single dollar is about 0.004 inches in width, if you were to take a crisp $1 bill. Well, if you were to stack them up, $1 trillion is a quarter, if it was in a pile of $1 bills, would reach a quarter of the way to the moon. And so we are spending $4.5 trillion in healthcare every year right now, which means we're actually exceeding the distance of a pile of $1 bills that would reach to the moon and beyond every single year. And almost twice that has been spent now on COVID relief, of which $600 billion is still left. And again, we start saying billion, trillion. People will slip and inadvertently say billion when they mean trillion. We've gotten to these crazy numbers. And, the president is trying to pass another $22 billion COVID-related relief package. And that seems trite in comparison to these other numerical figures, but 22 billion is still a staggering sum of money, and we need not to be numb to these levels of spending. And COVID can no longer be used as an excuse for them, as right now, if you can believe the World Health Organization, you look at absolute deaths, it's actually behind falls as a global cause of death currently.
Wow, that's a stunning number, but it also we talked in the last segment about subsidy. This idea that the money has to come from the government, or it's not you're not going to be able to get health care. I think is a con that needs to be called out, don't you, Dr. Savage?
Oh, absolutely, and they say it comes from the government, but that obscures who it really comes from. It comes from you. It comes from me. It comes from our own pockets. So unfortunately, we give the money. That's one of the things that actually obscures how bad the cost spend in healthcare is because we think the government is paying for it, but in reality, we're all paying for it ourselves. Where that money comes from and the true costs are obscured because we don't pay for it all in one fell swoop. You don't just get the bill and pay for it. If you did, you probably wouldn't do it because the pricing is so absurd. And instead, those costs are buried within deferred wages through employment contracts. They could have given you the money that they spend on health insurance instead as wages. So imagine a family of four being offered a $28,000 raise. But instead they get it as a healthcare policy. It's obscured in taxes. It's right. It's paid for in co-pays and in other ways. So again, and then we subsidize false pricing. So these things are vastly overpriced. And the reason I know that is because we're able to access these exact same services for many times 1/10 the cost that they're charged to insurance companies. So, and that's obscured. So people don't understand how mispriced it is. And the only way to perpetuate a falsely priced system is to obscure and subsidize it. And that's exactly what we're doing.
And it actually winds up, not just exacerbating and obscuring, it actually makes it worse because each time you do it, not only does it devalue the currency a little bit, making that dollar you subsidize somebody's health care worth 90 cents and then 80 cents and then 70 cents. So therefore you need more to match it. But it also takes away that commercial connection between the consumer and the provider that would say to a doctor, hey, my patient can't afford this because there is no longer that concern. Insert name of health insurance company or insert government agency, they'll take care of it. And so the rates are whatever they feel like they can get past the bureaucracy.
Yeah, it absolutely changes how you fundamentally think about healthcare. And there's a concept of value added. If you were to go to a store and buy a product and they say, well, for an additional cost, we'll add this onto it, you're doing something that generally makes that product or service better. But in healthcare, we have massive additional costs with no value added. We have billing and coding structures, humongous administrative expenses that I would argue not only don't make the experience better, but actually make it worse. And if you've ever had to struggle with a medical bill, you know what I'm talking about. I had once a $10 charge from my children's pediatric office, and these are wonderful doctors. I know them. I know their staff and things of that sort. They were within the same hospital system that I was part of at the time. But, and I knew we were being billed $10, and it probably didn't make sense for me to take the time to argue the charge, but I was I just wanted to try to fix it. So it took me several hours of phone calls to fix what was a $10 mischarge because the system is so labyrinthine and complex. Mm-hmm. And that complexity, again, did not improve the patient experience at all. It actually degrades it.
Well, as a patient once of a major university health system in the Charlottesville area, I'll leave it unnamed, of course. And what was happening is also commonly what happens with patients is you start getting bills that seem like they're redundant or a subsidiary of another bill. And hold it, I paid this bill, and who's this part, and why am I paying? And you start to feel like, hold it, how come I'm getting 6 bills for one doctor visit? And I finally wound up walking into their collections office, which surprised them a little bit. And I said, listen, give me $1 figure of all the money I owe you. I don't care how it's divvied up. I don't care which one goes to this department and which one goes to just give me $1 figure and I will write you a check. And I had my employer front me the money off my salary just so I didn't have the credit hit on having all these things falling into collections because I didn't know one was coming from another. But that is something that daunts people about the healthcare system also, doesn't it, Doc? Especially when you start to deal with, then you add the government on top of it. It makes it even worse.
Yeah, and that's a wrap price, what you're referring to, and most industries do that. You don't buy a car and pay separately for the tires and the bumper and every other thing. You pay for the car. And that's I kind of call them gotcha bills. We're a very unique industry. I don't know any other industry that do this, where you obtain a service and you don't know what the price is until after it's acquired. And it was interesting. I was once at a White House feedback session, and they had some of the insurance company people were there, and they were fighting against the transparency rules that would say you have to say the price up front before you do it. And they were arguing that somehow knowing what the price was would actually make it more expensive. Well, that was the first time I've ever heard that argument. And it would seem absurd to me to say you go into a Walmart and you see a nice TV set that you want. And the best way to get a good deal is to have no idea what it costs until after you buy it. That's just an absolutely ludicrous argument, and yet it was one they were trying to make to continue to obscure those pricing. And what's nice to know is that within medicine, wrap pricing does actually exist. There are cash pre-surgical centers that are cropping up and are very analogous to what we're doing on the primary care front. And really synergize well with what we're doing. And the classic example is the Oklahoma Surgical Center, which is giving cash prices, wrap prices. So you know what preoperative care costs, you know what the surgery costs, you know what the surgical center costs, you know what the anesthesiologist costs, and barring complication with the postoperative care costs. And you know that going in prior to doing the procedure. And as you experienced, unfortunately, that's not how it exists in our Byzantine structure within the insurance model, where you get a trickle of bills that come in over months for people whose names you don't even recognize that, can literally catastrophically wipe people out. And 70% of medical bankruptcies occur in people who have insurance. Gee. So I would argue it's not mitigating that catastrophic financial loss, which is the entire intention of insurance.
I didn't know that part of it. That is a stunning revelation to think that, these are people. What role should or what warranty should their insurance, pick up in the fact that all of a sudden some bill was left unnoticed and slipped through, I guess, the copay cracks?
Yeah. So my whole concept is that keep the money in your pocket. If the coverage is structured to cover catastrophic expenses, it will by necessity be much, much, much more affordable. And then what we have to do is bring back, home ec and other concepts of teaching the youth how to manage money, because in the credit card era, many people spend money without any thought of consequence. So that when they save that money, instead of going out and blowing it on a TV that they didn't know the price of, bad joke on that regard, back to what I was saying before, they would actually save the money, again, maybe through a mechanism like an HSA pre-tax. So they could create a rainy day fund. So if that unexpected expense occurred, that was several $1,000s, but not of an unbelievable amount of money, which is when insurance really is needed. Now they have it, tax optimized within an account that they can access to cover that unexpected expense. In 2009, my own family, at that time, that was the first time I'd ever heard of HSA accounts. And we decided initially, I thought, why in the world would I want a higher deductible insurance plan? But I started doing the math, and I realized that essentially for every dollar I took at risk on myself, meaning in the deductible, my premium was going down almost $1. So that meant even if I used up all that money, I was essentially where I started from with the more expensive insurance plan. But the difference was if I managed those funds appropriately, I got to keep that money. The HSA is beautiful because it's your money. You own it. It's not job locked. If you move jobs, you keep that money. And in fact, it even can go into retirement and help you with retirement medical expenses when most of them actually occur. So, but anyway, over a period of years, with the savings alone, we saved over $22,000 within an HSA account with just the difference in premium costs that we invested in the HSA.
Wow.
The difference in costs from the high-level program to the high deductible program to the more expensive Cadillac type insurance that my hospital was offering at the time. And I only did that for like 3 years. And within that period of time, with growth, it became over $22,000 and is far more than that today.
Dr. Chad Savage is on with us. He's the founder of Direct Primary Care Center in Michigan and is the author of an amazing piece about COVID spending spree in healthcare. Talk about this premise that COVID and the government can be the only one because it's a public health emergency, and every day turns around, it becomes more and more clear that it wasn't as dire as the government made it out to be, and there are a million different intransparencies that just lead to more people thinking that there are untoward things going on behind the scenes. Every intransparency leads to another conspiracy theory on this. I mean, public health is certainly something we should all think about, but in it, I think we've forgotten about personal health. Dr. Savage, is that a fair point?
Oh, absolutely. One of the things that I talk about a lot in some of the presentations I do is that if you increase the cost of primary care, people utilize primary care less, not surprisingly. But what that results in is a doubling of those savings on the primary care front in hospitalizations. So it's a penny wise, pound foolish proposition. Primary care should be affordable. The best way to do that is to get all the wasteful processes that we have in our offices dealing with insurance companies and the government. And just as an example, I do have an idea of how much waste that is because my own practice decreased our overhead by 50% by discontinuing dealing with those billing systems. Sure. That's how many staff we hired to simply try to work those claims. Mm-hmm. But when you think about that savings, you think, well, yes, you're saving on the front end with the primary care doctor, but you're spending twice that in the hospital. That's not only financially a terrible, terrible decision, but that's people getting sick. That's people suffering. That's people being hospitalized, in some cases even dying. So all of this is based in human experience. Well, we talk numbers, but the reason we care about numbers, economic situations, healthcare, all these are fundamentally human issues and have a toll on people's lives.
Well, and we've talked in the past on this program with Dr. Paul Marek and Dr. Pierre Corey of the Frontline COVID-19 Critical Care Alliance. Dr. Marek tried to testify before the Virginia General Assembly, but he was given all of 1 minute to do so, and then gavelled out and actually escorted out of the chambers by Virginia state troopers at the behest of the chair of the committee for simply saying, hey, we want permission to treat sick people with readily available medicine to make them well again. And Virginia wouldn't hear him at all and called them conspiracy theorists and QAnon or whatever the rhetoric was. But what you're talking about is breaking out from this government model stops them from being able to control what did President Trump's bill call it? The right to choose. So if you had a doctor that said, well, I have this stuff and it seems like your case would lead to use of insert, ivermectin, monoclonal antibodies, hydroxychloroquine, you name it, they could try it. And it's a personal relationship rather than a governmental bureaucratic one where, any changes in decision are made glacially.
Yeah, exactly. And unfortunately, as you move more and more towards a single party payer system, what people don't realize with that is that when they think in their head, they think this is great. Whatever type of care I want to access, it'll be free. But that's not what it really is. It's controlled. Whatever care they allow you to have is paid for by the government. And what do you do when that doesn't fit with your belief system, what you need personally? So a single party payer option is a single option. this is it. You have no choice. I've talked to people because, I've kind of floated around on my beliefs on this over time, and it's only through deep contemplation that I've come to where I currently am. And, I could understand the appeal of the concept of a single party payer until I started really thinking of the consequences of that. And a lot of these people, I realize that's kind of what they believe. Well, it's whatever we do now. It's whatever I want, ideally, just free. And that's just not what it is. It's totally controlled by a third person who may not know you, may not understand you or your personal needs. And a lot of those people go, well, but that's okay. If I don't agree with that, I can just go buy it out, on my own. And no, that's the concept of single party payer. There is no other option. That's it. You either get it or you don't, and you don't. There is no free market option.
Well, this is what I think the President Obama's chief economist, Paul Krugman, admitted on ABC television, that though they weren't called death panels, they were called advisability of care panels. And of course, they would try to control costs of things. And you see it in places like England, where, an 80-year-old is denied some sort of treatment that they would get almost immediately in the United States because, well, you're 80 and either there's you're not generating tax revenue anymore, or well, you're 80, and that's just not a decision I want government bureaucrats making, Dr.
Dr. Savage, fundamentally there's an ethical question too, and the sad truth is we live in a world of finite resources. So the fundamental question there is rationing. At what level does rationing occur? Because we do rationing all the time, whether we recognize it or not. Why don't I buy 20 hamburgers when I go to McDonald's? Because I don't need 20 hamburgers. I don't want to. It'd be bad for my waistline and many other things. We have limited resources. So when we control those funds, we are constantly rationing for ourselves. And that's okay. That's where the decision making should be for rationing. What do you want? What do you not want? So where should that decision exist? Should that exist between the doctor and the trusted doctor and patient to make the decision that's best for that person, utilizing the resources that they have stored up? Or should that be subjugated to a third party, and that's someone who doesn't know them, may not care for them. And there's a concept of first, second degree, and third party transaction. A first party transaction is where you use your resources to purchase something for yourself. And when you engage in a first party transaction, you care about the quality and you care about the price. A second party transaction is more analogous to buying a gift for someone. And in that case, you're not flippant, but you maybe care a little bit less about the quality, but you sure care about the cost because you're using your own resources. A third party transaction is when you're providing something for someone else that you're purchasing with somebody else's money, in which case you tend to care much less about the cost and the quality of those services. And again, that's what we have in the United States.
Dr. Chad Savage is on with us, founder of YourChoice Direct Care. If you want to look at what they do, YourChoiceDirectCare.com. And what was the organization you said that sort of is holding? You said there's a conference of direct primary care doctors.
Certainly, it's Docs for Patient Care Foundation, and our annual conference is called the DPC Nuts and Bolts. And we have lots of resources online to help physicians convert to this model. It's scary. Doctors are not taught how to be businessmen anymore. Yeah. It used to be that medical schools taught people, the physicians within the medical schools, essentially how to open a practice. They are not anymore. So they're terrified, and they believe that the only option is to become employed. But that's not true. It is nowhere near as complex. The startup costs are actually reasonably low. I think I started my practice for around $10,000. And the freedom you have to actually be the true advocate of the patient, whereas in the normal system, the patient is essentially the substrate through which the financial transaction occurs between the doctor and the insurance company. In the DPC model, we are the advocate of that patient. And that goes back to the noble cause of medicine. Many doctors went into medicine because they thought that what they were going to be doing, they're making sacrifices to get to that point. But what they thought they would do when they were finally physicianed is very noble, and that helps restore that nobility within our profession.
Amen to that. Dr. Savage, thank you so much for visiting with us. It's a joy getting to know you. You're one of the best economists we've ever had on here, never mind physicians. So, and I have a dear friend who's written written a book called Assume the Physician. It was right at the beginning of Obamacare, very kind of tongue-in-cheek, almost Douglas Adams look at what was wrong with healthcare. Since we started there, I figured we'd end there with a book tip for you. You can read his stuff at realclearhealth.com. Again, it's YourChoiceDirectCare.com. Dr. Savage, thanks you so much for joining us this week on Freedom and Prosperity Radio.
Pleasure, Joe.
And joining us next, legislative liaison for Americans for Prosperity and one of the adjuncts in our Virginia Education Opportunity Alliance, Ben Knotts, on Freedom and Prosperity Radio next.